So that's how you are going to treat the MDR and then the this tuberculosis. Okay, so this regimens is very important. So you can also search it from NTB guidelines. Okay, so this is the NTB guidelines, which is a PDF format, which is been available National Tuberculosis Program of Nepal. Okay, so the guidelines, the recent guidelines is available in that website. You can read that also. Okay, so this is the all the recommendations from that slide, okay, PDF. So now considering, so now we have to consider once starting the TB treatment, always there will be a high chance of having a liver toxicity. Okay, so this is the clinical thing that you are going to encounter in your clinical practice. So what happens? What to do? What to do? Okay, so what to do if the patient develop the liver disorder? Okay, so this is very important. So these are the things that you are going to have a side effects. So side effects, it can be a patient can have anorexia, nausea, is because of the rifampicin. So what we have to do is give you tablets last thing at the night. Then abdominal pain is there, and then patient has a joint pain mostly with the pyrazinamide. You can use the any NSAIDs. So you can use the aspirin, or you can use the naproxen and all these things. Okay, so you can use, and even if it is very high, then you can advise for the diet consultation. Okay, so diet, so high protein diet should be reduced, and if it is you can use the xanthine oxidase inhibitors like aripinol, or you can use the fevoxstat. Okay, so that is how you are going to use for the joint pains if there is hyperuricemia. Then burning sensation in the feet, isoniazid. So you have to increase the dose. The patient has developed the INH-induced peripheral neuropathy. In that case, you can use the pyridoxine as a high dose of the 100 milligram. So for the prophylactic and for the prevention, you are using only 10 to 20 milligram. In that case, you have to use the high dose of pyridoxine. And always explain the patient for the change of the color of the urine or any secretion, even the sputum, even the stool, so that can change into orange to red. Okay, so to advise the patient. And if the patient has a skin itching, rash, is mainly because of the streptomycin, stop anti-TB drugs. And if the patient has a hearing difficulty, then stop streptomycin. So in mainly case of the streptomycin causing toxicity. Dizziness is mainly a neurotoxicity. The patient can have a taking streptomycin. Jaundice, most of the anti-TB drugs except ethambutol and streptomycin. Okay, and you can have a visual impairment like ethambutol and generalized, including rifampicin. So these all are the things that you have to consider. So if the patient develop having a liver disorder or renal disorder, I told that, so the most unstable or severe liver disease is there, fewer hepatotoxic drugs will be used. So the regimens used for the liver disorders, like patient with the hepatitis virus carries. Okay, so if the patient has a hepatitis B and hepatitis C, then a history of acute hepatitis and the current excessive alcohol consumption can receive 2 HRZD and 4 HR, provided that there is no clinical evidence of the chronic liver disease with close monitoring of the liver function test. So 2 hepatotoxic drugs rather than the 3 in the standard regimen that you can use. So you can use the this regimen as 9 months of isoniazid and rifampicin plus ethambutol. Okay, so there's 9 HRE until or unless isoniazid facility is documented. Okay, so you can use this as a treatment. So isoniazid, rifampicin, and you are taking out the most hepatotoxic, that is pyrazinamide. So expert consultation is advisable in treating the patient with advanced or unstable liver disease. So clinical monitoring of all the patient with the pre-existing liver disease should be performed during the treatment. So what is the consideration in the renal disorder? So reduce the dose of the ethambutol 15 milligram per kg. Okay, and then the pyrazinamide 25 milligram per kg, you can use that as a thrice a day per week, and continue the regimens the same, is a 2 HRZD and 4 HR. Okay, so this is the ideally you have to reduce the dose of ethambutol and pyrazinamide in the patient with renal disorder. So if the patient has ATT-induced hepatitis, after taking the tubercular drug, the patient developed hepatitis. So this is the most common side effects that you are going to get in your clinical practice. Okay, so what to do if ALT is more than 3 times of the normal range and the patient is symptomatic, or 5 times the normal range without the symptom. please follow the following guideline. Okay, so this is the guideline which is given by the NTP guidelines. So hold all TB drugs for at least for 7 to 10 days. Wait until the symptoms resolve, and liver enzymes is less than 2.5 times the upper limit of the normal before restarting the antitubercular drugs. So note, the patient with a severe TB should be treated with the another regimen that is known as a modified regimen. So if in the severe TB, if the patient has a CNS tuberculosis, if the patient has TB pericarditis, these are the severe TB. So in that case, you cannot stop the drugs for the longer duration. So in that case, you can use the modified regimen in that the streptomycin, ethambutol, and levofloxacin until they are well enough to attempt the reintroduction of the other antitubercular drugs. Okay, so that's the advisable. So how to reintroduce the drug? So stepwise reintroduction of ATT after the drug-induced hepatitis. So in the first day, you are going to give the rifampicin plus ethambutol. Okay, so ethambutol you are continuing. Then rifampicin, you increase the dose to 450. Continue. If the patient is asymptomatic on day 3rd, rifampicin 600 milligram per ethambutol, and you again check the liver function test. Okay, so liver function test is normal. Then on the 4th day, you add on isoniazid starting with 100 milligram. Okay, so and then if the patient on the 5th day, you add on isoniazid plus ethambutol, and in 6th day isoniazid plus ethambutol that you are going to use. Okay, and check the LFT and give 1 day of period, and then the day 8 you are going to add on pyrazimide with a low dose of 400 milligram, and then 9th day pyrazimide 800 milligram at ethambutol and pyrazimide and ethambutol. Okay, so this is how you are going to, if the patient just check LFT. And this it should be started on day 1 as a full dose regarding the pyrazimide. If the signs and symptoms recur at any day of reintroduction or follow-up, LFT shows LLT more than 3 times of the normal range, irrespective of signs and symptoms, discontinue the responsible drug and modify the regimen and the duration of therapy as required. Okay, so this is given by a technical working group. So what they have seen, if the rifampicin is omitted, so after adding the rifampicin, the LFT is increased, then you are going to do the 18 months of total duration of the treatment with intensive phase of isoniazid, levofloxacin, ethambutol, and streptomycin of 2 months. And the condition phase, you are going to use the isoniazid, levofloxacin, ethambutol for the 16 months. And then if the INH is the drug responsible to increase the liver function test, then you have to omit the INS. Then you are going to give the regimen for the 12 months. In that, you are going to use the rifampicin, levofloxacin, and ethambutol and streptomycin for the 2 months. Okay, 2 months, and then continuation phase, in that you are going to use the rifampicin, levofloxacin, and ethambutol for 10 months. Okay, so this is the another thing. If you are going to omit the pyrazimide, then you are going to, the regimen should be of 9 months, in which you are going to use the rifampicin, isoniazid, and ethambutol for total 9 months. Okay, so this is how you are going to treat the ATT induced hepatitis. Okay, so this is, so with this I'm going to conclude the lecture of the tuberculosis. So in the tuberculosis, you should know about the pathogenesis of tuberculosis. So what is the natural history? What are the risk factors of tuberculosis? What are the signs and symptoms of each pulmonary tuberculosis and the other extra pulmonary tuberculosis like abdominal tuberculosis, how the patient will present. Abdominal TB is also important, and the patient with the CNS TB, meningitis, and all these things you should know. Okay, so and then what are the investigations that you are going to do, and what are the newer guidelines for the NTB regimen. So this is the guideline you should know to reproduce. So this is the guideline that you should know. So new TB cases and retreatment cases, what you are going to do. So this is the slide which is very important for you to know and always been asked to you. And then for the drug resistance TB, and you should know about the short notes can be asked about what is multi-drug resistant TB, what are the XTR TB. Okay, so these are drug resistant TB short note can be asked. So you have to write the definition of multi-drug resistance, what are the extensive drug resistance, and what are the treatment guidelines, what are the drugs which you are going to use, levo, drugs, all these drugs you have to write, and then you have to write the regimen. Okay, so regimen. So mainly is a regimen is the shorter standardized treatment regimen. The intensive phase 4 months ideally you are going to use. If there is a sputum positive, then again you have to add for another 1 month, and again repeat it, or then you have to add on another 1 month of the intensive phase. Okay, so this is how you are going to introduce the drug for the shorter standardized treatment regimen. Okay, so regimen and then the continuation phase, and then you should know about what are the contraindications of going for the standardized shorter MDR TB regimen and the individualized longer MDR TB regimens. Okay, so these are the things that you should. So this slide also gives you a good overview of starting the which regimen to choose. Okay, so standardized or individualized longer MDR TB. Okay, so if the pregnancy, disseminated meningeal or central nervous system TB, all these in that case you are going to use the longer one. Okay, so longer one. So this is how you are going to treat the tuberculosis. So I will advise you to read the TB from the Davidson itself, and then you can look for the National Tuberculosis Guideline. Okay, so NTB book, which is available in the website of National Tuberculosis Program, NTP program guidelines. You can read that for the tuberculosis. So that is to be your reference for the tuberculosis. Any questions? Okay, questions are? Any questions?
No, sir.
I know. Takes okay. Now regarding your theory exam, so theory exam के Friday सम्म जे lecture हुन्छ त्यसको question आउँछ हैन. So for theory exam, your theory exam in Sunday हैन?
Yes, sir.
And so Sunday is your theory exam. So is mainly we are going to have that, and the group A will have a OSCE after the theory exam. And so theory exam. So OSCEs. So what you have gone through in the clinical practice, clinical classes, and all the also theories that can be asked in the OSCEs, and practical. And practical कहिले सोधेको थियो मलाई त्यो दिन Monday उ छ भनेर, अनि त्यही दिन practical A1 को भयो भनेर हैन. सो त्यो केही छैन, 1 घण्टा एक्जाम हो तिम्रो theory. So we cannot take whole group on the same day. किन 10 बजेपछि मात्र एक्जाम दिँदाखेरि is not possible, and the patient पनि हुँदैन वार्डमा. So we are dividing on that. In that case, you are having only a practical exam. Either it can be the only a viva only, table viva only. You are going to see in the case, and otherwise you can get the one case as a practical exam. Okay? So practical exam. So that will be a format for your exam. Right? So best of luck for your exam. Bye.
Thank you, sir.
Thank you, sir.
Nephrology में के class भाषा हो तुमको? Sachin? Sachin is there or not?
Sir.
Nephrology में you have the lecture on hematuria. Dr. Bikramले lecture लिनु भएको थियो. थाहा छैन. Dr. सागरले के लिनु भयो?
ट्रान्सप्लान्ट को एक्युट किडनी इन्जरी हरु
के एक्युट किडनी इन्जरी
अनि ग्लोमेरुलोनेफ्राइटिस.
हजुर सर.
एक्युट किडनी इन्जरी भइसक्यो लेक्चर?
भइसक्यो सर.
हजुर सर.
एकेआई भयो, ग्लोमेरुलोनेफ्राइटिस भयो, नेफ्रोटिक नेफ्राइटिक सिन्ड्रोम के भन्नु भएको छ?
छैन सर.
ग्लोमेरुलोनेफ्राइटिसमा त भने होला नि त.
तर त्यही ग्लोमेरुलोनेफ्राइटिस को छ।
ग्लोमेरुलोनेफ्राइटिस नै भन्नुभएको छ।
अनि एप्रोच टु के हेमाचुरिया भयो विक्रम सरले लिनु भएको थियो कि थिएन अगाडि होइन किनभने वी हेभ टु एड अन होइन तिमीले ल्याएको छैन भने त्यो भन्नु पर्यो नि त
विक्रमको एउटा मात्र क्लास भएको थियो हाम्रो।
के भयो त त्यो कुन चाहिँ क्लास भयो एप्रोच टु हेमाचुरिया भयो कि एप्रोच टु प्रोटिन्युरिया भयो कि कुन चाहिँ भयो थाहा छैन। ल ठिक
सर एप्रोच टु प्रोटिन्युरिया र त्यसपछि एक्युट किडनी इन्जुरी दुईटा मात्रै भएको छ।
एक्युट किडनी इन्जुरी अनि ग्लोमेरुलोनेफ्राइटिस लिनु भएको छैन सागर सरले
सायद छैन सर छैन सर त्यसमै एप्रोच टु प्रोटिन्युरियामा भन्नुभएको थियो
त्यो एटेन्डै गर्दैन के अनि के ल्याए छैन भनेर सोध्नु त कुरा भएन नि त आई एम आस्किङ यु होइन पिपुल होइन ओके नि भन्नु थियो होइन किनभने त्यो ल्याएको छैन भने मलाई इन्फर्म हुनु पर्यो कि होइन सो यु हेभ टु बी इन्फर्म किनभने वी हेभ टु के नेक्स्ट रुटिन आउँदाखेरि त्यो राख्नु पर्यो नि त होइन सो यु क्यानट गो जम्पिङ त्यो नगरिकन यता गयो भने त केही पनि बुझ्दैन नि त होइन सो द्याट्स वाइ है सो एकचोटि हेरेर मलाई इन्फर्म गर है सो आई विल गिभ यु दिस फर के कामना र कामनादेखि नै मैले होइन सचिनले हेरेर मलाई भन्न सिआरले है के लेक्चर है सो एसएमएस अहिले उसमा बाई गरौँ है
ओके सर
ल
थ्याङ्क यू सर
थ्याङ्क यू सर
ओके